I don't know, Eric. By my calculation, there's 17 minutes left, so I think we each get 8.5. So anyway, so I'm from the Health Services Research Department at the VA, and I'm very proud of the stuff you've already heard about both our research and our practice in terms of pain care. But I'll begin with my conclusion, which is I think even as a system that I think is ahead of everybody else, we still struggle with how to take the evidence about what works to actually deliver reliable, scalable, accountable, and affordable multimodal pain care that's patient-centered. So, and I think that's where our research is increasingly having to focus. So the reason the VA is a good place to study pain care is because we know that both chronic pain and opioid use are higher in military veterans. But there are other unique aspects that make VA a good laboratory. So we're a national integrated care system that provides care to 6 million patients in any 1 year at over 160 hospitals and over 1,000 sites of care. So we really need to figure out how do you take anything that works at one hospital and scale it across a system. We have everything from little C-box with one contracted clinician to large level 1 tertiary facilities. A lot of our veterans live far from care, so we're especially interested in modalities that allow for self-care. Telehealth, supporting caregivers to take care of veterans who have pain. We have a global budget, so we have to think about value. We cover a lot of interventions, but every hospital director has to manage their own budget, and if they have to start paying for more acupuncture in the community, it's got to come out of somewhere. So we need to be able to show that these things are providing value. I think as Ben Kligler, and thanks to people like Ben Kligler, we really have made great progress. As of 2015, 93% of our medical centers were already offering at least 2 CIH modalities. Chiropractic has been standard in the VA for over a decade now, and we have a wide variety. His office leads an initiative where every one of our 18 networks will have a facility that has at least 5 options to offer. But we have a challenging population. So as people have alluded to, pain rarely exists alone. That's especially true in veterans where there's a high burden of comorbid mental health disorders, substance use, social isolation, all the things that can impact the pain experience. So this is just an indication of the fact that for patients who have pain in the VA, they're already getting this care. This doesn't distinguish whether they're getting it on their own or through the VA, but over half have been using some type of complementary integrative therapy in the past year. Stephanie Taylor, who did this research, is here. She's in the overflow room, I think. And the leading ones were massage, chiropractic, and mindfulness. Woo, that clock moves quickly. Anyway, so this is just to remind people, though, that we are part of a larger research enterprise in the VA, covering everything from biomedical to rehabilitation research. And if you look at our pain portfolio, which currently has 150 projects, there's a lot that's in rehab and other areas, but this shows you a breakdown. I'm afraid the fonts aren't very readable on that, but we have biobehavioral, tech-based, activity-based, and complementary integrative health. The complementary portfolio is the one that's grown the largest, and this just indicates that we're studying a range of conditions, a range of interventions, and a range of outcomes, including quality of life, costs, and opioid use. This, I think, has already been referred to. We had a state-of-the-art conference very similar to this a couple of years ago. Kurt Krenke helped us organize that, along with others that are here. We divided the therapies up into manual, exercise, and behavioral, showing that there was enough evidence to support a range of stuff. We also, Bob already showed the slide about supporting multimodal care, and so that has guided our clinical innovation. So what are the evidence gaps? For most therapies, we still need to study different ways of delivering them, especially when we're trying to scale across a broad organization. Can we do this as groups? Can we do it online? Do we need really 12 visits to the acupuncturist? As a agency that contracts out for this, what qualifies as a good quality acupuncturist? This is sort of Sherry Link's question. How do we know if we're getting this in the community, that we're actually getting well-qualified providers? And for multimodal care, we still struggle with how do we actually implement that. We've done a lot of the research showing the benefits of multimodal stepped care. I was on a call with our 18 chief medical officers for all our networks, and I asked them, how many of you have this routinely available in primary care? And it was a minority. I said, why not? And it said, well, we have other priorities. Okay, so even when there's things that they know are good, I don't think the VA is unique. There are always other things that are competing with in terms of priorities. This is just close now. This is, oh, you can come up and stand by me, yeah. So these are just a variation of our trials, including some funded by PCORI and others, but just showing that we're really trying to get at alternative delivery models, questions like cost effectiveness, and questions of is our low intensity options as good as the high intensity integrated approaches that are most effective. So I already gave you my conclusions. I think we have a growing evidence base for these individual therapies and for multimodal step care, but we still have a lot of questions to ask, to answer, to help a system like ours figure out how do we actually make this a reality across a system that's as diverse and with patients that are as diverse as served by the VA. Thank you.